I think from today we are on Bhageshwar's
We are live, please.
So welcome everyone to this course, certified course on phacoemulsification in different situations. And today we are on module 4, which is phacoemulsification in pediatric cataracts with a galaxy of speakers. We have our program director with us, Dr. Harshultak, who's actually conceived this entire course. And this course is going to be running in 13 modules. After the end of the course, you will have to answer 15 questions. And even if you don't take the questions now, you can take them later. There is every option to do that. And the recording of this is also available on YouTube, on Facebook, and following which also the questions can be taken. After you've completed the course, depending on the answers which are given, and also depending on our assessment, the certificates will be given from the All India Ophthalmological Society Scientific Committee portal. And I would now request Dr. Harshultak to please start this module on phacoemulsification in pediatric cataracts.
Yeah. Thank you so much, ma'am. And once again, thanks to AI Scientific Committee, Namrata ma'am, for giving this wonderful opportunity. So this is OPMS, one problem, many solutions. We know that we do encounter difficult situations in Phaco. So first module was on Phaco in black and white cataract. Then we did on Phaco in small pupil, Phaco in post-polar cataracts. Now it's very important today that we know the attendees, they should know how to deal with pediatric cataracts, nuances and finer points to take care in dealing with pediatric cataracts. So today we have with us our moderators, Dr. Vaishali Vasavda, and who is from Jaipur Raghudeep Eye Hospital. We all know. Thank you so much, Vaishali. We have another moderator, Dr. Divya Chaudhary, who is pediatric ophthalmologist at Rawat Eye and Phaco Surgery Center, Jaipur. She's trained from Shroff Eye Hospital. Welcome, Dr. Divya. And we have speakers today. Dr. Vaishali will be speaking. And we have Dr. Jyoti Matalia from Narayan Netralaya, Bangalore. We have Dr. Shruti Nishant from Chennai. And we have Dr. Savleen Kaur from PGI Chandigarh. And we have expert panel with us, Dr. Love Kochogave, who we all know is a renowned cataract and refractive surgeon from Kolkata, and he has special interest in pediatric cataracts. We always have been seeing his amazing videos. Thank you so much, Dr. Love, for sparing out time. We have Dr. Jasprit Sukhija, another very prolific surgeon, has special interest in pediatric cataracts and strabismus. So thank you so much for joining for this course. Now I'll hand over to the moderator of the session. Dr. Divya?
Yes, sir. I would like to thank AIS and Dr. Namrata ma'am and Dr. Harshul sir for giving me the opportunity to moderate the session. Today with us, our first speaker is Dr. Vaishali ma'am.
So a very good afternoon, everyone.
Dr. Vaishali ma'am is currently working as the director in Raghudeep Eye Hospital, Jaipur. She is affiliated with Raghudeep Eye Hospitals, Ahmedabad and Jaipur. Ma'am is quite renowned at Jaipur and has done her fellowship at Raghudeep Eye, followed by Muran Eye Center, Salt Lake City, USA. Ma'am has a special interest in pediatric cataract and clinical research. She has more than 70 peer-reviewed publications in national and international journals. Ma'am is a member of various All India and international societies. She has also received various awards for scientific paper presentations and scientific video presentations. Today, ma'am will be talking about the finer points in pediatric cataract.
Thank you so much, Dr. Divya. Thank you, Namrata ma'am. Thank you, Harshul bhai, for having us here and for actually putting up such a interesting course, and that too, as we see, on a working day during working hours, which makes it much easier for a lot of us to attend. So thank you so much again for this. Can you see my slides here?
Yes.
I have no financial interest, and I'm just briefly going to talk about some surgical aspects that are different, or let's say they need more attention in pediatric cataracts. So unlike in many parts of the world, in India, both trained pediatric ophthalmologists as well as cataract surgeons, we all perform pediatric cataract surgery to a smaller or a larger extent. So it's very important that we understand the nuances or the differences that you need to keep in mind when you're operating these young eyes. Often they are not just small versions of the adult eye, and therefore, I think like with any surgery, the main principles still remain. Even in pediatric surgery, micro instrumentation, microsurgical maneuvers, and what is different from an adult standard Phaco is the fact that you need to have very good bimanual dexterity, and the role of adjuncts such as ophthalmic viscosurgical devices also becomes important when you perform your maneuvers, particularly on the anterior and posterior capsules. So if we talk about the paradigms of surgery today, in my mind, three things are very important. Like I said, number one, minimally invasive surgery should be chosen, whatever the paying status of the patient or not. Second, uveal tissue respect is of utmost importance, because the iris in a pediatric eye will not forgive us even if you just touch it for a moment. So it has consequences that are much more exaggerated in the post-op period. And finally, I would say safety over ego. If you cannot do something or you feel that you are stuck, it's better to leave the child aphakic, for example, or refer it to a colleague whom you think will be able to manage this small eye better. So ego has no role in a child's eye, because you are dealing with somebody's life and their family's life for the time to come. So again, to start off with, how I like to do and what I think is very important is to make even the smallest of incisions with, I use a dual bevel knife, which is sort of like an MVR knife. So you could use an MVR design, but even the side ports have to be only the size that you need, and they have to be self-sealing. So a stab incision, quick in and quick out, often results in a leaky wound and therefore should not be made. The other point I wanted to make here is that I have made three 1.1 millimeter paracentesis. Before I begin the case, I do not make a main incision or a larger incision until I feel confident that now I'm going to be implanting the IOL. So that was in terms of the incision. Even though you are going to suture them, be very careful that you make small and self-sealing incisions, as many as you need. Now, these are videos, again, I took for anterior capsule management, because these capsules are very elastic. The one thing that I like to do for every case, and particularly when I was learning, is to stain with trypan blue. This does two things. Even if you like, you can see here, you have an excellent red glow. But I like to stain because it makes the capsule more visible at all times. It makes it a little more less elastic, and therefore it's easy to maneuver, and it gives you a good guide of the size of the rexis. Now, an anterior capsular rexis manual is the best, but you could use other modalities like femto, zepto. But frankly speaking, in most scenarios in India, it's not very practical or financially feasible. The end point of the size, if there is a lamellar cataract like this, typically you follow the boundaries of the cataract. However, roughly you want around somewhere between 4.5 to 5 millimeters. It's always better to make a smaller rexis than a larger, because if you end up large, these are elastic capsules. So you need to really, if I can replay this video again, I like to use a straight cystotome, 26 gauge needle. I don't bend it. And once I make the nick, I use microrexis forceps, and I can do it through one incision, or I can always change my hands and use all three incisions. But here it's important to grasp and regrasp many times and pull the capsule to the center and upwards. Then only we will be able to maintain the required size of the rexis. Now you can see here, this is one of our fellows. Now it's okay to be slow. It's okay to grasp 10 times, and you can always use both incisions or even 3 incisions. So it's important that you are comfortable at every stage. You don't have to prove anything by doing it in one go. You can grasp and regrasp every 2 or 3 clock hours, and make sure you have a good control whenever you are performing the anterior capsular rexis, because these capsules are highly elastic, and typically cystotome will not work. Now here is another pretty common scenario which we see in pediatric, is the presence of these fibrotic plaques. Now it could be traumatic, it could be a non-traumatic cataract also. But you see here again that I'm using one microrexis forceps to hold and give traction. And in the other hand, I'm using a micro incision scissors. Now, if you don't have access, you can always ask your retina colleagues who can lend you, and you can always use these fine instruments. And as you can see, I have made one more side port here, which normally I would not make. But because I want ease of ergonomics, I don't want to be awkward in cutting anything. So control is very, very important. Make as many incisions as you need to be comfortable when you're performing the surgery. And I think the time is gone when you make a large incision and use even Utratas is not a bad idea, but in my opinion now a lot of Indian companies, all instrument makers have these really elegant microrhexis forceps. So it's worth investing in one of these. Now the lens removal is not a difficult thing, but typically bimanual IA is something that we always prefer. Now for this, you will need a little higher vacuum because the nucleus, the cortex, it's more sticky. So I like to use a vacuum of 400 to 500, and I use a modest flow rate of anywhere between 18 to 20 cc per minute. And I always do bimanual, particularly in a pediatric eye, so that there is 360-degree easy access and there is no distortion of the incision. And notice until now that no main incision has been created. I'm only working with 3 side ports. Now, this is where the real differentiation between the adult and pediatric cataract comes in, is that you have to do something to reduce or delay the onset of visual axis obscuration or PCO. And the best thing is to perform a posterior capsulotomy, either manually or with a vitrector, and in young children. So for me, anybody below the age of 5 years, I will also perform an limited anterior vitrectomy to remove that scaffold on which the lens epithelial cells can proliferate. So how do you perform the posterior capsular rhexis? It's only more scary. It's not that difficult. It just takes few cases to get used to. The important thing is here I use a bent 26 gauge cystotome, but I don't use my cystotome vertically. I use it slanting. As you can see here, the bevel is slanting. It's not vertical down, so that I don't rupture the pretty solid anterior hyaloid phase. And I create that initial nick. Now, once I've done that, and I can see that, again, I will remove my cystotome and go back with my forceps. And I can always use another port with a spatula or a Hoskin forceps so that I can manipulate the globe to have a good glow and good visibility. So slowly, slowly you progress. Now, the other thing I wanted to highlight is before you perform an anterior capsular rhexis, in pediatric eyes, please use sodium hyaluronate, a 1% or more concentration. No financial interest, any brand will do. But it's not very conducive to perform these surgeries under HPMC. And the same thing holds for posterior capsular rhexis. In posterior capsular rhexis, don't inflate the bag too much. Just inject a little bit in the center so that you have some space. If you inflate it too much, the capsule goes too down and then it's very difficult to manipulate, plus you are more likely to rupture the anterior vitreous. Now again, you can see here that I have changed my hands and I'm slowly and in a very controlled manner. It should end in the way and the place and size that I want to. So it doesn't have to be 100% round. There are no marks for a circular rhexis, but yeah, it should be of an adequate size and centration so that the central vision axis remains clear. And in terms of whether I would perform a vitrectomy, yes, if the child is below 6 years and I'm planning an in-the-bag IOL implantation, I will also perform a limited anterior vitrectomy, which I like to use a pars plana trocar and put my vitrector through the pars plana and the irrigation remains through the limbus. But you could do a bimanual limbal anterior vitrectomy. Now, only once I'm ready for IOL, that's when the main incision is created. Now, this is a case where an in-the-bag IOL implantation was performed, and therefore a single-piece hydrophobic acrylic IOL. Again, there is no financial interest. You could use whatever you prefer, but it has been proven in many studies and literature shows us that the hydrophobic acrylic IOL is both uveal tissue friendly as well as lens epithelial cell proliferation is lesser as compared to hydrophilic. So in terms of PCO, these lenses are preferred in younger children. So once it is in the bag, then you can, the other important thing why I took this picture is even if these are 1.1 mm incisions, they should be sutured. And this one I've taken a box suture. So children rub their eyes and you cannot control all this. So please take sutures. You could take Vicryl if the child is not likely to follow up. But I like to use nylon because I find that when Vicryl degrades, it causes a lot of irritation and mucus deposition. So I have shifted to using 10-0 nylon. And this is again how I perform a pars plana limited pars plana vitrectomy. 1.5 millimeter behind the limbus, I put in a trocar, which I borrow from my retina surgeon. And my normal, the Phaco machine vitrector goes through that and irrigation goes through the limbal incision. And here again, it's important to use a low bottle height, but the highest cut rate possible on your machine. And you can see that a vitrector exists. So if you are not confident, or in situations like this where you have a plaque or it's a very young child, put in the lens in the bag, then go with your vitrector and do a capsulectomy and vitrectomy as I am doing here. My machine supports 4,000 highest, but it depends really on what you are using. The last segment of my talk, which I wanted to discuss, is can we altogether avoid vitrectomy? Because vitrectomy means in these young eyes, you don't know where is the vitreous base, whether and where to enter. When you do a vitrectomy, the oxygen gradient changes. And it has been shown that it might be a precursor for glaucoma and it can change the way your axial length grows following surgery. So is there a way we can put in an IOL safely and yet not do a vitrectomy and not have a PCO in the future, very early in the future? So this is the technique of optic capture, which is not new, which Dr. Howard Gimbel had described for pediatric eyes in 1994, way back. So what is basically done here is this works best with a 3-piece foldable IOL, any company. So here you can see that a manual anterior and posterior capsular X's have been performed. The 3-piece IOL has been put in the bag. Now I'm using my Leicester hook through my side port to push the optic down and slide it through the posterior capsular X's margin. And you can see that is happening like a noose. And this is done on both sides. And this is how this dumbbell-shaped appearance shows that the optic capture has been achieved. And we will see in the subsequent animation how capture will help us. Again, another scenario of this white cataract, where this is how the cataract started off with. This is how we performed a manual anterior and posterior capsular axis. Again, if you want to do a capture, your posterior capsular axis should be to the tune of 4 to 4.5 millimeters. Too large will not allow a capture, and too small also you are likely to damage the zonules or cause a tear. So you need a well-centered and adequately sized posterior capsular axis if you want to perform an optic capture. Now here again is an end picture where a 3-piece hydrophobic acrylic IOL was put in the bag and then it is just slid gently behind the posterior capsular axis margins. Now, at the end of every procedure, whether you have done a vitrectomy or you have not done a vitrectomy, it is imperative to inject preservative-free triamcinolone. And in India, we are lucky we have several brands that give us preservative-free triamcinolone. So we don't need to dilute or anything. And this is injected in the anterior chamber. Now, I like to leave it in the eye at the end of surgery for 2 reasons. Number one, if there was a vitreous strand, it will show me and then I can go with my vitrector and remove that. But the rest of it also acts as an anti-inflammatory agent. So I won't wash it off. I leave it at the end of surgery in case the compliance with drops is not very good for the parents. Now, this is an animation to show how in the bag IOL can move because it's still in the bag. There's nothing that actually holds it or anchors it, versus if you do an optic capture where your optic is pushed behind the posterior axis, it will not move either laterally or in an anterior posterior direction. So this actually makes it more stable. Also, it creates a barrier through which the lens epithelial cells cannot penetrate. So it reduces or delays the visual axis obscuration. And this is what we found in our way back, several years back in 2017, we published this 1-year trial where we compared in the bag IOL and vitrectomy in children who are younger than 4 years. That means you would normally do a vitrectomy. In the other group, we randomly put an optic capture but did not do a vitrectomy. And both groups at the end of 1 year had similar outcomes in terms of PCO, in terms of inflammation, and in terms of glaucoma. We now have 7 years follow-up of this study, and they are still both are looking very, very good. So I think that is one thing. And the last thing, can we do something for older children? Now, once infants and small babies is a completely different ball game, but in India, unfortunately, we do see children at an older age. Now, this is a 5.5-year-old boy with developmental cataract. Now, apart from doing a cataract surgery, can we do something to give him better combating of amblyopia and better visual rehabilitation? Because not every child is going to wear the glasses like you prescribed. So this is the cataract, how it looks on the microscope. And again, like we showed, we start with making an anterior capsular excis and IA is performed. There's nothing unusual about this case. Now, having done a posterior capsular excis, now I am inflating the bag with, again, sodium hyaluronate. What I want to say is that unlike in adult cataract, you just push in a bolus through the incision and everything inflates. Here, you intentionally put small amounts of OVD into the space between the anterior and posterior capsule. So you inflate the bag and not as a bolus. You put little amounts so that there's a uniform inflation. Then I use a toric IOL and I put it, and I have this marking to guide my implantation. So I have not performed a vitrectomy because he's a grown-up child and he's very cooperative on the slit lamp. So I have put in a toric IOL, and the advantage of doing this is that in the immediate post-operative period, I understand that maybe 3 years down the line, the eye is going to grow and I might end up with a spherical or an astigmatic refractive error. But today, right now, when he's already 5.5 and amblyopic, it helps to correct every degree of refractive error, particularly astigmatism, to combat the meridional amblyopia. So this is what the child looks like, and he's doing absolutely well, 6/6 unaided for distance, but near, obviously, he needs 2.5 addition. So I think for any child above 5 years who can cooperate for a topography and a biometry and has a regular astigmatism on the cornea of more than 1.5 diopters, you can consider astigmatism correction. And this is also what we published. So I think to end my talk, technical outcome is very, very important. But the whole game of pediatric cataract, if you don't match it up with your visual rehabilitation and particularly the quality of your unaided vision, then you lose half your battle. So thank you once again for the opportunity, and thank you for a patient listening.
Thank you so much, Dr. Vaishali, for that very nice talk. So I think we have some questions for you, Dr. Divya.
Yes, Dr. Love, sir, I would like to ask you some questions. Sir, what age group are you are preferring the posterior capsulotomy and anterior vitrectomy?
See, there's no harm doing what I do. Even in early teens, I will do a posterior capsular excis and anterior vitrectomy. There is one difference what Dr. Vaishali has shown and what I do is I have given up manual posterior capsular excis. So I do only with cutter, and that saves a lot of time, and the IOL is always placed in the bag. And second thing, but in that case, what she has shown, the optic capture, that will not be possible in when we are doing with cutter.
So you go through
only in
pars plana to do that posterior capsulotomy, or you go
no,
through
no,
limbal
through the
route
limbal
only?
route only. I do
Limbal
it.
go behind IOL and then do.
Yes. First
Yeah.
do the IOL implantation, and then with a 23 gauge cutter, you go behind the lens and do a maybe 4 millimeter posterior capsular excis with a high speed cutter. It's very smooth margin.
Yes.
And Dr. Jaspreet, sir, I would like to ask you, like for beginner surgeons like me, like do we prefer to put IOL before the anterior vitrectomy or after? What is easier for us to do? And sir, till what age are you putting sutures, sir? And till what age we should put?
Yeah. First of all, that was a very good presentation, Dr. Vishali. And so basically for beginners, yes, it's always safe to put the IOL first. So doing a posterior excis can be difficult. You don't know where the vitreous attachments are, how big is your Berger space. It differs in every child. You might have vitreous coming into your rexis for beginners, which might lead to enlargement and complications. So it's always good to put the IOL first and do a vitrorexis. Second question is sutures. So sutures is like universal. I'll put it for less than 3 years, 3 and less than 3 years. That's universal. Older children, yes, I do gauge on the table what's really happening. If I find a lot of posterior vitreous pressure coming at the end of surgery, I would do that. I would put sutures. But in other cases, probably I'm just leaving them. So it's like something can be argued. I mean, it's like not going without a seatbelt if it's safe. So while your accident is going to happen once. So it's always better, I would recommend put sutures. Okay. And then with your experience, probably once your experience and know your patients, how they behave or how they are going to be in their post-op period, like some children are quite aggressive, uncooperative. So in those children, you really require sutures. In aphakic, where I leave the children, aphakic in young children, probably even toddlers, I don't apply sutures because without an IOL, probably the chances of positive pressure coming into the anterior chamber is very, very low because you've already done a vitrectomy. So it's a nice soft globe, basically.
One point I want to make here regarding when you're putting in doing a vitrectomy after putting in IOL, what you need to understand as beginners, when we are doing the vitrectomy, we tend to lift the IOL up. So you have to be very careful, otherwise it will pop out of the back. So ensure your elbow is below the level of the child's head so that you're not lifting it. You are doing from below and then ensuring that you can see correctly. Because invariably the IOL comes out and then you don't realize. So it's a good technique, but tend to follow. Try to keep your vitrector almost horizontal so that you're able to do it correctly and the IOL doesn't pop out.
Dr. Jaspreet, one thing about the positive vitreous pressure, just recently, maybe a few months back, I have developed a hack for that. Just for 2-3 seconds, I remove the infusion cannula and continue with the cutter and come out. Then the back falls down back, and this positive pressure, what we see in pediatric cataract quite commonly, that doesn't occur in those cases.
Yeah, so I do it with an air bubble. So just before the irrigation coming out, probably I am insert an air bubble.
And I would like to ask the experts, like, what are, sir, your experience with optic capture versus anterior vitrectomy? And is any age group we should follow for optic capture the way we follow for anterior vitrectomy?
You just, I think Savelina had written a very good paper on optic capture versus in the bag. And we found similar results in both of them regarding the PCO rate. So the main purpose of doing it is stability and avoiding a visual axis of obscuration. So we didn't find any difference over a 2-year period. Over a few years, what we've seen is that in the younger children, there is some haze which comes up when you don't do a vitrectomy. So even when you're doing a posterior optic capture and not doing an anterior vitrectomy, there is a very mild haze which comes up behind the IOL. So that's the only thing which bothers us. Otherwise, it's a very good procedure. I mean, you just have the haptics in the bag and you're doing something very good. So we've just improvised on that. And in children, we are now doing a bicapsular capture. So it's like lens, your lens at the bag. So it's bag in the lens, sorry. So it's like the haptics in the sulcus and the optic going behind the posterior axis. So your capsule is all empty, it will just seal. So nothing going to proliferate because the margins are going to seal. So we are doing it in selected cases, and probably once we come out with the publication, hopefully then we'll maybe be able to generalize it and recommend it.
I want to make one comment that what Dr. Sukhija said is a very good idea of doing a bicapsular capture. That means put your IOL first in the sulcus and then push the optic through both anterior and posterior axis, which is very easy. I mean, it's robust stability, but only one catch I want to tell for all the beginners: you have to be as skilled and experienced like Dr. Jaspreet, because in case that capture comes off, you don't want a pediatric IOL in a sulcus unless there is already a traumatic large defect or something. So sulcus is the least preferred location for pediatric IOLs. So therefore, be very, very mindful and make sure that both your rexes, your posterior rexes is of an adequate size so that you could push it through and the capture should remain. And in the long term, like Dr. Jaspreet said, probably that haze behind the IOL. We don't see that much haze, but there is one thing of the phimosis. They do younger babies will develop over a period of time a narrowing, just like anterior rhexis, fibrosis, and phimosis. But typically, this helps their vision in some ways because it's more like a pinhole effect. But that is something that does come up when you see them over a long period of time.
And how about using trifocal and these multifocal lenses in these children? Are any of you using at what age group?
We published, I think, above 6 years when the axial length is stable, probably, and very selected cases. I mean, these are amblyopic children. So toric IOL is a good option. I mean, as the presenter was saying, I mean, you are preventing astigmatism. You are rather preventing amblyopia. It's not just amblyopia, that is one part, but the aberrations because of the astigmatism is another part which adds on to the amblyopia. So that's a good option. But coming to these multifocals and trifocals, you really have to be very selective because these are amblyopic children. And so it's not that easy. Plus, in younger children, probably because of multiple images forming, the chances of a clearer vision, a better contrast are obviously balance those risks against giving them just 6x6 visions. So you have to customize your approach to every child.
Okay, I think that let's move on to the next talk, Dr. Vaishali.
Yeah. So next, Dr. Divya, are you going to introduce her? So I think next we have Dr. Savleen Kaur, who is going to talk to us about PHPV or persistent fetal vasculature and its surgical management, which is, I think, one of the most challenging topics. And we keep discussing about this, and still we really don't have all the answers. So, Dr. Savleen, we are really looking forward to some very usable practical tips from your side. And welcome to the webinar. Thank you.
Thank you so much, ma'am. It's my pleasure to be part of this eminent panel of speakers. I hope I'm visible, and I'm sorry I'm not feeling well, so my voice might be keeping in between. Can you? Am I audible?
Yeah.
Am I audible in my screen
Yeah,
visible?
yeah, we can see your slides.
Okay.
Yes, yes, Dr. Sablin, please
Okay,
go
sorry.
ahead.
So, as we've already discussed, there are a lot of challenges as such a pediatric eye offers, and a case of persistent fetal vasculature adds on to those problems. The most important thing in these cases is to actually detect that you have a case which is of PHPV. Typically, you will find them unilateral with a microphthalmia, and there are various subtypes of PHPV as well as the variety of PHPV that we see can be mild, moderate, severe. And the consistent feature that we see in these cases is this neovascularization, which can be integrated with the anterior or the posterior capsule, and that makes the surgery difficult. So I'll be briefly showing three cases. The first case is that of a 4-month-old child and had a severe persistent fetal vasculature. So I have made the standard ports, side ports, and as Dr. Vishali has beautifully illustrated, you can you can make a main port also, depending on how comfortable you are. And the anterior capsule is actually capsulectomy that you do in these cases because the aspiration is not the problem. The problem is once you have aspirated this nucleus, you start seeing the integration of the vasculature with the posterior capsule, which often starts bleeding on table. So this intraocular bleed, if you have access to a cautery, I think that has made our job very easy. These persistent vessels can be cauterized. As you can see, we are doing it in a circular fashion, as many vessels as we can see. And then I've given a stabbed incision in the posterior capsule and then removed this opacity with the help of a cutter. So when we start removing the opacity, then you see the capsule starts opening up. And now you can see the elongated ciliary processes that are typically seen in cases of severe PHPV. Now, it is important in these cases to cut between these ciliary processes. I think this is the most important step in all cases of PHPV, because even if you have a clear visual axis and you do not cut, the opacity kind of comes back. So be sure to cut between the processes, and it also opens up the donut of this opacity that you see. In this second case that I'm showing, we couldn't make out that it was PHPV until we were halfway through the surgery. So you see now the pupil is dilated, we have removed the cortex, and now we are visualizing the vessels on the posterior capsule. Again, similarly, we have cauterized it in a circular fashion around the disc, and using a vitrector, we are cutting and making an opening in the posterior capsule. Once you have cauterized, you might still see some bleeding. If you have not cauterized the stalk, then the stalk can bleed and lead to postoperative vitreous hemorrhage also in these cases. But I haven't implanted IOL in the first two. The third case is this patient does not have microphthalmos. So it's a fairly good sized eye, good biometry. And once I have done the aspiration of the lens matter, now we are we've implanted the intraocular lens also. And now with the help of a cutter through the anterior route only, I have used the vitrectomy probe, the 23 gauge probe, to cut the opacity as well as the stalk along with it. And after cauterizing, of course. So luckily it did not bleed, and a fairly good centration of the IOL, and we kind of opened up the opacity and made it into a posterior capsulotomy, achieving a good centration. So there are select few cases where you can implant an IOL. You can see the retracted stalk post-operatively in the case. Very severe PHPV, sometimes OCT ultrasound helps us, because particularly say in this case, it was a chronic case of keratopathy associated with PHPV. The OCT told us that, okay, we could see the posterior capsule and an integrated opacity in some places, but these cases have the worst prognosis. As I said, only in select cases you can implant an IOL, and as I have learned over the time, and I have stopped putting IOLs in most of these cases which are severe form of PHPV. This last case that I'm showing is one of the first few that I did. I thought that the PHPV was mild enough. So you can see just one vessel of the posterior capsule. The cortex was aspirated, and while I was doing the aspiration, intraocular bleeding started, because the vessel that I could see, considering that it was a mild PHPV, it started bleeding. So I went ahead and cauterized this vessel after completing the aspiration of the lens matter. And because I felt it was a well-sized eye again, and I had achieved a good clearance of the visual axis, I thought I will implant an IOL. So you see this vessel that has bled. We used a cautery to cauterize this vessel, this single vessel, 2-3 vessels that we could see, we have cauterized that. And then after that, I went ahead and implanted the intraocular lens and cleared the axis, as much as I could. But what happened was that after I had
You're not able to listen. No, it's not moving.
Your signal seems to be weak, Dr. Savli.
we had thought that we had achieved just a second.
I think there is some problem with the connectivity. She will log in again.
So while we are sorting this out, Dr. Love, I had one question for you, Dr. Jasprit, both of you. Two questions. Number one, when you see a child with a PHPV, which is typically a unilateral cataract, how does your counseling change for the parents and the family? And second, what is your strategy for IOL implantation?
See, first is if it is clinically, we are generally able to make out whether it is a very thin stalk or it's a full-blown PHPV. So visual prognosis in these cases are not very good. First, and if left untreated, may lead to retinal detachment, phthisis, and other things. So the main purpose would be preserving the anatomy of the eye first. That is the first line. Second line is some residual vision, some useful vision. If the child has, then that eye acts as a stepney. And IOL, she has quite well demonstrated that if it is associated with eyeball size problems, then and if it is you are not getting enough space, better to leave them aphakic.
Dr. Jaspreet, any tips on this?
Yeah, so again, of course, if it's quite an angry looking PFE, I would really not put an IOL and be very skeptical on doing the surgery as well in these patients, depending upon all the ultrasound findings. Well, if you are really going to operate on these patients, you have to be careful about the bleeding. You have to cauterize everything. The other thing is these children require repeated surgeries. There are a lot of inflammation, fibrosis coming on, visual axis opacifications. The main purpose of doing surgery is basically to let them see. So repeated surgeries are there. And the third thing is, of course, avoid the sulcus in all these cases if you're planning an IOL. And where it really becomes difficult, because in a unilateral cataract in India, contact lens fitting is really out of question here. So they're going to be amblyopic. They already have deprivational amblyopia, plus you're giving them maybe plus 20 or so if they are phakic. So probably it's just that you have to counsel the parents about the aggressive approach for patching what you can have and how the visual outcome is going to be. I've done maybe a couple of patients where obviously, because you're never sure of the anterior axis in these patients, it might be too large, it might be eccentric. So probably in selected few cases, I have done a posterior optic capture in these, and the stability of the IOL is much better as compared to if you're doing a simple IOL in the back. But again, the first preference is IOL in the back. These are cases where obviously the things are unpredictable when you just start to operate on the case. So this again, PFE is case to case. There's not just one size fits all. And
even after cautery, many of them will bleed.
Yeah, I mean, it does happen if it's a very florid PFE, they do bleed. And post-op also, sometimes you have these, I've had one or two cases where you had vitreous hemorrhage here.
So Dr. Savlin has joined again. Dr. Savlin, can you share the last case which you were showing? We'll finish that.
Really sorry for that, and I'll share the last case what I wanted to, I think, say. So here, what I was trying to show was, as Sir said, these cases might require multiple surgeries. So this is a case that I thought went really well, but as you can see, post-operatively, the patient required multiple surgeries in the form of membranes which had formed behind the IOL. So the OCT is telling us that the IOL was okay, but the posterior capsule that had actually, to begin with, the PHPV part had actually reproliferated and had gone completely behind the IOL, completely becoming what it was originally. So the whole visual axis was obscured again. And that's why these cases do require multiple surgeries, because they'll keep on getting this visual axis obscuration, and which I feel is much more when you put an IOL instead of aphakia. So that's what I prefer in most of the severe cases of PHPV. And that's all I think I wanted to show. They can be mild, moderate, and they can be severe, and the severest of forms will keep bleeding if you do not operate them, if you do a good cautery. And acknowledgements to Dr. Jaspreet. I'm glad I'm presenting this before him. So thank you.
So yeah, thank you, Dr. Savlin. That was really wonderful videos, and I think the kind of experience that you would have being at PGI Chandigarh is very few people would have dealt with so many cases of PFE. But I really caught on to one point that Dr. Jaspreet brought out here is whether you would operate or not. So like we have been discussing, not everything is about can I do it? Maybe you can, but what are the consequences going to be? And are you going to be able to handle those consequences effectively? So you might more than one round of counseling with the parents is very important for all of these aspects. And the slightest doubt, I feel, if you feel that you don't have enough experience, not only surgical, but to manage these eyes in the post-op, frequent EUAs, getting them back in follow-up, doing all the necessary surgeries then I think it is not a bad idea to refer them to somebody who you feel has more experience with these kind of cases, because whatever you do, the prognosis in certain PFV eyes is really, you just cannot control it. So that is, you really have to be very, very careful and don't just jump into it until you feel you have mastered the regular or the normal pediatric cataract. Any comments or any questions from any of the panelists, Dr. Jyoti?
Yeah, I just want to say, yeah, sometimes as a pediatric ophthalmologist, we can say a no, and it may be required to say a no. Like I have just seen a PFE before I came for this webinar. His corneal diameter was 6 millimeters. So in these kind of cases, it doesn't make sense to do it. So sometimes you may feel, but if there is going to be no visual potential, the other eye is absolutely normal. So we really have to think whether we are doing it. It's not about just operating. As rightly Dr. Vaishali mentioned, it's not about our ego, whether we can handle it, but whether the child will really benefit from it. So that is what finally it is. If we are doing it for getting vision and we know it will not come in because the other eye is absolutely normal, then we have to decide whether is it worth going in or we can just leave it alone. So we should also learn to say a no when it's really required.
Yeah, I think a great point that despite all, you want to help the child, but if you end up creating a thicycle eye, not only have you not given vision, but the child is scarred with the cosmesis for life. Although these eyes are many times smaller eyes, but even having said that, you don't want to add to the misery of the child and the parents.
And here I can just say that in this case, if you decide not to do, what you can actually do is start using conformers. So that forms the orbit. So eventually when you want to put a prosthetic eye or whatever you want to do, then it will match the other eye. So this is what you can start even if you're not planning the surgery.
Great point. That I think is a very good point to start talking to the parents about making it more cosmetically acceptable. So I think if we don't have any other questions, we move on to our third talk of the session, which is by Dr. Jyoti Matalya and Dr. Savleen. Before we move on, I forgot to introduce you. She's Associate Professor in Pediatric Ophthalmology and Strabismus at PGI Chandigarh, and she has vast experience, as you just saw. Her work speaks for her more than anything else. And Dr. Jyoti Matalya is the head of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at Narayan Netralaya. She also heads the PG training program and has trained more than 40 fellows under her till date. So welcome, and we look forward to your insights on one of the most tricky and something where all of us get stuck or lost at some point or the other. How do you manage a traumatic eye in a child?
So thank you. You can see my slides?
Yes.
Yeah. So I'm going to be primarily talking on managing complicated pediatric cataract, primarily talking on how to handle traumatic ones. Yeah, so basically giving you tips for success. So before we go on, and I've heard Dr. Vaishali talk very nicely about how and what you should be aware when you look at pediatric cataract. 1 minute. I think there's some problem with that. Just 1 minute, I think. Sorry, just got. Yeah, so I'm going to be starting importantly. So have a good vitrectomy machine, which is very, very important. And what we also said, a microrhexis forceps, because that allows a closed chamber approach. Something for the beginners, what I prefer is endolite, because this, which our retina colleagues have been using for years, if you put it limbal over the limbal tangentially, you can see the posterior capsules very well as the anterior vitreous also. So this is something that you can use as a modification to achieve what you otherwise cannot see. Now let me divide my entire talk into how to handle anterior capsular defects, posterior capsular defects, combined ones, and subluxated cases. So now this is the case, first case that I want to show you. Next case was a mature traumatic cataract following blunt trauma. After releasing the posterior synechiae, a defect in the anterior capsule superonasally that extended to the equator was noted. After adequate staining of the anterior capsule, a good capsular excess was fashioned. Capsular excess was fashioned, centering over the pupil without incorporating that defect. Thereby, the integrity of the capsular bag was maintained. Routine irrigation and aspiration of the cortical matter was performed carefully, and a foldable 3-piece intraocular lens was implanted away from the capsular tear. This technique allowed implantation in the bag. So what it tells us is, in the beginning itself, if you've tried to open up that particular defect, the whole bag would have opened and you would not be able to put the lens correctly inside within the bag. So importantly, yes, keep that particular fibrotic edge as you can see here. This will allow the lens to be put in the bag, and always choose a 3-piece, because if you're putting a single piece and the bag opens up, it's not good to put a 3-piece in the sulcus. Yeah, so now coming to the next part, which is the posterior capsular defects. So this is a case of a mature cataract with a posterior lenticonus and a PC dehiscence, as you can see clearly with the shine flux image. So you know there's already a defect. So here you would aim for a small anterior capsular excess, because in case you cannot put the lens within the bag, you can at least allow it to put in the sulcus. The other important aspect is avoid hydrodissection, because if you do that, you can cause that particular area of dehiscence suddenly to give away. So that is important. Here, to maintain fluctuations, I've used the anterior chamber maintainer, which helps us note the existing posterior lenticonus and the fibrotic edges. Yes, so we prefer to use the anterior vitrector under the endoilluminator. You can clearly see it. And the IOL in the sulcus, but remember to capture it so that you can maintain it in place. Now, other cases are when the posterior lenticonus is very large and you have a pre-existing posterior capsular opening. As you can see, it's huge. So in this case, it's best to put the lens first within the bag. And after that, you can do a vitrectomy and then eat up the opacified edge. So this way, you're ensuring the IOL is within the bag and you've got a good size of your rexus anterior as well as posterior. Now, this is another case of interesting patient who had a high astigmatism and a membranous cataract. Next case was a membranous absorbed cataract with a PC plaque and a high astigmatism of 5 diopter. A customized toric intraocular lens implantation was planned. Intraoperative 0 to 180 degrees horizontal marking was done. Due to the wrinkling of the anterior capsule, a careful capsular excess of adequate size was obtained using trypan glue and micro-rexus forceps and scissors. The PC plaque was carefully removed and an anterior vitrectomy was done in the area of the pre-existing PC dehiscence as is seen here. The endoilluminator was used for the same. The intraocular lens was implanted in the bag and adjusted along the markings. At the final follow-up, the intraocular lens was nicely in place. So here what I want to specify is this patient had a significant high toricity, and hence using a customized IOL helped, because what we are planning to do is have that particular toricity already incorporated. All you need to do is put it between 0 to 180. So it was easy to put it and it was a plate haptic. So as we discussed, certain cases of toric IOLs can be implanted in children to get the best effect to avoid amblyopia. Now let's look at other conditions where there's a combined anterior and posterior capsular defect. And that starts in patients who have an obvious penetrating injury like this. So you can see lens matter already out. Yes, you aspirate the matter, followed by a good corneal suturing, which is done. And then since the lens matter is already out, you go ahead and see if you can get a good amount of anterior capsular excess, if possible. This is followed by doing a normal irrigation aspiration. And then you notice here that there is also an anterior capsular rupture as well as a PC rupture. So both these ruptures are noted. Then you use a vitrector, which at the same time can be used as aspirating the cortical matter and at the same time doing an anterior vitrectomy. And this way you entirely do a lens cleaning and a vitrectomy, making a proper opening of your PC. So we have a primary repair in which a patient who presented like this had a good suturing done. So when you then plan to do your IOL implantation, which is an important step, so you allow these particular corneal sutures to well heal. After that, you do a suture removal, which is usually 6 to 8 weeks later. Suture removal is then followed by 2 weeks of waiting, and then an IOL calculation is done, because by then your cornea is healing well. And this patient then had a anterior and posterior capsular adhered to each other, at which step I decided to go and do an IOL implantation. So as you look at here, basically first you release the posterior synechiae. You notice that the anterior and posterior capsules are fused together because this is what you had left behind. And so you say, and you can make out it is so tough. I'm trying to use a vitrector, but you can see it's very tough. You cannot go in. Then I'm using a side knife to see if I can go from the area of clear capsule to it, but it is still difficult. Then trying with a capsular rhexis forceps, but it is difficult. So then we use a micro rhexis forceps and scissors here to try and make a nice opening and get circular. Then with the two-hand technique, I'm using and pulling with one hand with the forceps and cutting with the scissors. Now that you've made a nice circular opening, you can easily then do a vitrectomy and make it of the adequate shape. And this can be then followed by an IOL implantation. And then again, as I said, you do a 3-piece IOL because this is what is going to be in the sulcus. You never put a single piece within the back, within the sulcus. So IOL implantation post-surgery, you can see it as well. Inside, sometimes if the opening is big enough, you can do a good IOL capture. This child had a good vision of 612 plus 2.
Case of absorbed traumatic cataract following corneal tear. After releasing the synechiae, a thorough exploration of the capsular bag showed a wedge extending over 2 clock hours of absent anterior and posterior capsular support. So after aspirating the cortical matter, the remnant of the anterior and posterior capsules was retained as a support for the IOL, except for the central area to clear the visual axis. That is evident with the endoilluminator. Keeping in mind this capsular defect, a foldable 3-piece IOL was then injected in the sulcus with minimal manipulation to be placed over the leftover scaffold of both the capsules to allow the best stability for the IOL. This is the final position of the IOL with a vision of 6 by 6 parts.
So try to have minimal manipulation, and then if you try to understand where your support is maximal, and there is where you will place your intraocular lens. So now let's look at the final part, managing traumatic subluxated cataracts or IOLs. Now this is a patient who presented following trauma, had 120 degrees subluxation with a fibrinous membrane over the with prolapse vitreous, as you can see. And I went ahead doing surgery. Remember, we do not try to release this membrane, because if you do that, then the lens will start wobbling and move downwards, where it will not allow you to do your capsular rhexis. So you watch for it. Try to look at what is required, and as importantly, use a trypan blue for staining because it reduces the elasticity as well, and you can get a better visualization. Always decompress an intumescent cataract. You don't want it to run away. The anterior capsular rhexis is centered over the lens, not over the pupil. After you've done the capsular rhexis, then I have tried to remove the membrane over it and done a good vitrectomy, so that now you can see the lens tilting down. But we are not worried because rhexis has already been done. Then the irrigation aspiration is commonly done. Here you put the CTR in the bag to inflate it. Now the area where there was a maximum subluxation, you try to use the CTS for fixation, and you prefer the Gore-Tex suture here, where the bag is fixed, the capsular bag with the CTS, and you have to ensure that as you put in, the CTS goes within the bag, but the eyelet is over the anterior capsule, and both of them are pulled to the area where there is a subluxation, followed by bearing it. You use the glue to close the conjunctiva. Again, a single piece hydrophobic lens is now put in because you can easily put it within the bag, and try to do it with minimal manipulation. And this is how the child is doing after surgery, and is doing fine for the last 3 years. And finally, this is a patient who presented with a subluxated IOL. When the patient came to me, I was wondering what it is. Basically, the parents gave a classical history that yes, IOL was put, but you look at it, it cannot make out. A UBM showed very clearly that the IOL was there, but it was displaced upwards. So basically, what had happened is post-surgery, the parents, the surgeon had not sutured the wound. It was an SICS entry, and also the child had ended up with a trauma. So let's see what happens when we go in. So it was a classical fibrous ingrowth which had extended onto the IOL. So first I made a side port on either sides, try to put the viscoelastic and trying to break the synechiae. And then you can see there's a big membrane. Then make an opening within the membrane, and with the rhexis forceps, try to start doing an anterior membranorhexis. So first I did it in one direction, try to get it superiorly, and then realize it's so adherent. So made the other side port, and now try to do the rhexis in the other direction. So, and when you get it, you realize it's so firmly adhered superiorly that it's best to cut it off. So with a vitrector, I have done it. Now you can see the edge of the IOL. So I decided to do a vitrectomy and eat up the posterior capsular opacification from behind. And for that, I've used the iris hook. So you notice the same side ports can be used for passing the hooks as well. And then with the vitrector, I've made the opening in the central part of your visual axis, a little below the IOL, as you can see. And that has shown that the visual axis is now cleared. We just need the central part, which is clear, and importantly, suture the wounds wherever necessary, because if they leak, it's going to create the same problem the patient presented with. So a pre-operative patient like this eventually came post-operative, is what we got. So what you need to understand here is we cannot be heroic and try to remove the IOL, put in. You see, the eye is in such a bad state. What we need to give the child is a clear visual axis, which we can attain by just doing this much. And that way, if we are able to visually rehabilitate the child, that is the best for it, because this was a 3-year-old child. And now the child is able to see well. So basically, in summary, when it comes to complicated or traumatic cases, do a stage procedure, leave some remnant of the capsules to allow a scaffold formation. Anterior vitrectomy should be done wherever indicated, where you use a high cut rate and low vacuum, because you're doing a limited amount. We are not going in for co-vitrectomy. Remember, single piece IOL always in the bag, never in the sulcus, in which case use the 3-piece, which can either go in the bag or in the sulcus. And amblyotherapy as and when needed, because we may do a good job, but if the child is not rehabilitated, especially in unilateral cataract, then we are not able to achieve what we actually went in for. Thank you very much.
Thank you. That was really comprehensive and a variety of different complicated scenarios, so well managed. Any comments, Dr. Love, Dr. Jaspreet?
Very well managed. Some part was a learning for me also.
No, actually, as pediatric doctors, we realize that sometimes each case is so different. So it's like a challenge.
And especially traumatic cataracts.
Oh, yes. And it's not that we can plan in advance. As we start operating, we realize, oh, this is the problem. Okay, we have to do this. Now we have to do this. So each step is something different. And we cannot...
Vortex suture, I wanted to ask, what is the thickness of that? And I've not used that. I generally use 9-O-Prolene.
So this is around 7-O Gore-Tex. The advantage I had is because I was in Narayan Netralaya Health City. The cardiothoracic unit is right there. And that is what the cardiothoracic surgeons tend to use. So that's how we got the person who gives it. But this is thicker. What you actually can use, even 8-O, but it is not available. So this was the highest what we could get it in Bangalore.
Okay.
And they say just because they are using it for their valves, it may be a better option than Prolene, because Prolene is known to break after 10 years. And Gore-Tex may turn, but we still don't have any future of what Gore-Tex done. But because our thoracic surgeons feel it's going to work almost lifelong, why not try it out?
I think what Dr. Jyoti showed is like every case is unique and it needs a lot of improvisation and you need to take many decisions on the table. So I think it's very important that counseling also should be very good, in these kind of cases. Wherever it's pediatric, they are pediatric cataracts and especially traumatic. So what all you take care in counseling, Dr. Jyoti?
So first, very important to tell the patient, the idea is that we are going to be clearing the cataract. There's no guarantee I'll be putting the IOL at the same time. We will also try our best, but it could be a stage procedure. So that is very important. What the patient is presented with, what I'm going to do, and putting in a lens, or if I'm going to give the option of contact lenses, that can be done as a next step. But at each step, that this will be one of the many surgeries that the child can face. So that we have to keep in mind. The advantage we have in Bangalore, we have a place where we get contact lenses. And to just add that for my pediatric cataracts, all my patients are on contact lenses. We have a very good company here. It's called Classic and PureCon, no financial interest. But they do give us the 18-hour contact lenses, which all my children do use. So they work really well. So if I'm going to keep my child aphakic, I have the option of using contact lenses at all. But yes, the parents should know that this may not give you immediate vision rehab. Repeated follow-ups are necessary for exercises, for checking IOLs. Possibility of retinal issues can come in because this is trauma. And that will be lifelong. So that's important that you need to have a follow-up. And at each visit, we keep on telling them so they are aware that they need to periodically visit us for maybe initially till they attain 18 at least.
So, those surgeries was very nice. They're very complicated. But two questions probably, which everybody would ask. These are the penetrating injuries with the bad corneal scars. How do you calculate the IOL power in these patients?
So as rightly seen, I would wait for the cornea to heal. If the cornea is not healing in time, sometimes I give contact lenses for the eye to get some vision rehab, obviously not balanced with toricity, but some amount of aphakic component to be given, or give glasses with aphakic value here, and for 50% of the time closing the other eye. Once the corneal sutures are healed, I would be removing the corneal sutures. 2 weeks later, we will do the IL calculation. Whatever, there will be a huge range, but whatever the mean K we get will be used. I never use the other eye's keratometry or the axial length. Whatever I can get in this, I will be using this. Until now, I have never had an issue where I could not get. So you will get an approximate K value, which I will use. Yes, over and above that, whatever residual comes in as a refractive glass power will be given thereafter. Sometimes we can give contact lenses also post-surgery if you are not able to get that benefit of refractive correction.
Yeah, so for these IOL, it's difficult to get a biometry with the optical biometers, where you have dense corneal scarring. Probably one can try a pentacam. That gives a better keratometry in these children as compared to just doing a routine biometry. It's there in the literature, and when I read it and I found it, and obviously things have changed for me when I have such complicated cases. The other thing is when to operate. You have a patient with penetrating injury, and the child has a cataract as well. So would you do it at the same time, or would you let the inflammation subside? What about the concept of age? A younger child would be treated differently as compared to an older child. So,
so I would think that it all depends on what type of injury is there. If I feel that the minute the corneal suturing is done, I would wait. If I feel within 6 to 8 weeks, I'm not getting a healing of the cornea happening, then I may go in and do a lens aspiration, followed by, as I said, a refractive correction with an aphakic correction for that eye. If I feel the cornea is going to heal within 2 months, yes, I will go ahead and get the corneal sutures removed, and 2 weeks later do the surgery. That's one thing which I can do. Obviously, during each time I'll be monitoring, because sometimes the lens, these kind of cases with penetrating injury have anterior capsular rupture. You have the cortical matter coming out. Patient can have raised IOP. We have to monitor. They can start, the cortical matter can start encroaching the endothelium, and you can have endothelial damage. So each visit we are watching it, but everything remains same. Then around 2 months of time before I remove it. But anywhere I feel anything is compromising the anterior segment or pressure going up, in that time you intervene early.
Yeah, even in children, probably, yes, you would like to intervene early as compared, because there is dense amblyopia, deprivational amblyopia probably is more prevalent in this.
Yeah, I think you have to go everything together. If you feel like I had a patient who had a glass injury, corneal tear was done elsewhere, it was not very good, and the cornea was just not healing, because where you have a corneal incision where we could have put 7-8 sutures, they had put 15 sutures. So the cornea was just not healing. So then we started doing a partial corneal removal, suture removal, allowing it to heal in between. And then we realized it was taking 4 or 5 months. So we went in and did a lens aspiration, started giving him rehab with that correction, because now the visual axis was clear. It's just that we cannot give him full perfect refractive error. But we tried doing it, and then with partial corneal sutures removal, then removing the next 50%, then removing the 50%, we allow the cornea to heal, and then finally went in with an IOL. Now that patient had such a big scar that corneally refractive correction with glasses did not help. So he went in for a scleral contact lenses. So eventually you may need to give him, depending on how he does, what kind of specific correction will depend on how his eye behaves. As you said, this is a very bad corneal wound that he had.
One question I had, Dr. Jyoti, for traumatic subluxations, what is in how many clock hours do you decide for scleral fixation, or whether it has to be fixated or only CTR has to be given? How do you take that decision?
So if there is less than 2 clock hour of subluxation, I will just put a CTR. But anything between 2 hours and less, anything from less than 180 degrees, I will go and put in a CTS. But more than that, I don't think it will work with a CTS. You may have to put a Cioni ring. But just 2 clock hour or 1 clock hour, if you feel, once you open, you'll get an idea. If you put a CTS and the whole bag gets well forms and moves back beyond your pupil and towards the equator, then I will not put a CTS.
In this case, it was maybe 4 clock hours.
This was a 120, 4 clock hours.
Cioni or double Cioni you'll put?
Double Cioni. One will not work.
Double Cioni.
So if there is like this had 4 clock hours, 120, then I can put in a CTS, it will stay. But anything more than that will not stay.
And decision about maybe double Cioni or a scleral fixation, fixated IOL, how do you take that?
No, so again on table, see, when you start the surgery, you realize if your rexus runs to the periphery, because these are very easy to look because I have done it. But there are times when you're starting the rexus and you don't have the support because part of it was subluxated. So in this case, it was good because there was a membrane and that was indirectly holding it. Now, if there is a subluxation and you're trying the rexus, because there is no pull of the zonules, your lens is a little wobbly. So your rexus does not come as perfectly it has to come. In which case, if you feel your rexus is not coming, you're not getting a perfect central, centration of your capsular rexus on your bag, in which case, you will not be able to go ahead and do your surgery, or your subluxation starts increasing, then you need to change on table, then a CTS may not work entirely.
And
people do 2-3 CTS also. They try to put in at multiple places and do that as well.
And in progressive diseases or like Marfan's and others?
I would not do it because it's eventually going to progress. And then we are bothering our retina colleagues by putting these kind of things. And then what if the bag drops in? So
in those cases, better to go for a scleral.
Yes. Now there are so many options of, how to hook those lenses. So in those, I would not do.
Right.
Thank you so much.
And what is the approach? I just want to know what is your approach for cases of microspherophakia, Dr. Love, Dr. Jyoti?
Same lensectomy, and if the size is permitting, then put a scleral fixated. But especially in these have to be older children, not in a very young child. My criteria is generally 8 years and above. If I'm doing a scleral fixation.
Yeah, basically, in these older children, I'm now routinely doing a Jamane in these patients. I don't really suture anything. Earlier, it was because the sclera is so elastic. I mean, it was difficult in younger children because the haptics in the sclera without suturing. The older children probably they are doing well. I mean, these 8 to 9 years old are really doing well.
Dr. Jyoti, I had a question. With these large corneal tears that you have, sometimes these penetrating injuries, and then you have these lot of sutures, like as you were saying, somewhere around 15 or so, and then you do these alternate removal. Is there a trade-off that we have between amblyopia and then holding on for cataract surgery for perfect IOL measurement? Like, what is your take on that? Sometimes, you would like to operate on them slightly earlier, especially in younger children.
Yes. So as I said, in that case, what I would do is I'll just remove the lens matter. Child becomes aphakic. You give him the aphakic correction because you've just done the lens matter. Then you'll have to put an IOL in the sulcus. You are not anyway sure about the bag status of these cases. But I've started giving him an aphakic correction because the cornea is not healed and I'm not going to and I don't prefer to put it. But because you're rehabilitating him visually by giving him the aphakic correction, allowing 50% of the patching as well, you are going to allow him to get, and then once your cornea heals, you go ahead and calculate the IOL on the basis of that particular keratometry. And because once this eye has got so many corneal sutures, the other eye keratometry will just not work. You're going to create more problems. So might as well keep him aphakic, get the value of that eye, only then go ahead and do it.
Got it.
Yeah. Thank you, ma'am, for such a wonderful presentation. Our next speaker is Dr. Shruti Nishant, ma'am. Ma'am is the head of Statistics Pediatric Ophthalmology, Neuro-Ophthalmology at Hospital MNI Hospital, Chennai. Ma'am is also a joint editor at TNO Journal and a reviewer at various journals. Ma'am has won various presentations award at Best Poster, Best Paper. And today, ma'am will be speaking on managing difficult capsules in pediatric cataract surgery.
Okay, once again, thank you so much for the opportunity, Dr. Harshul and Dr. Vaishali. Something that came up really, it's so great to be in front of stalwarts here presenting. And I'm going to take you all back to basics because we've had a lot of complicated scenarios. Now I'm going to take you back. The topic given to me was capsular access management in difficult situations in pediatric cataract. So to begin with, I would just like to know this is for the benefit of those who are starting out and maybe probably trying to hone their expertise on this particular step. And here you can see me handling the capsular access with the Utrata's forceps. And now you do have a lot of intraocular access forceps and all, but somehow I tend to be a little more comfortable because I like to have the hold of the Utratas and a little bit of movement that I do with my hands. So doing a good capsular access anterior and posterior is extremely essential for establishing the rest of the procedure goes well. So for posterior capsular access, I do the same, a small nick in a side way and always to kind of not overinflate the anterior chamber and And it's always good to use sodium hyaluronate to kind of, stabilize the posterior capsule nicely behind, and try to give a centripetal movement, and try to kind of keep grasping and re-grasping in a way that, you make sure that the circular part of it is retained. Now, it's important that, it's very tough to actually extend the posterior capsular excess because of the tightness and the tautness of the capsule itself. So let's look at some situations. This is an intumescent lens, and you can see me trying to press it, and you can see the way the fluid is bobbing in. So here you inject a high molecular weight viscoelastic, and then you see me going right through the capsule and then kind of decompressing it a little bit, and then using the intraocular rhexis forceps to kind of slowly navigate around. And I'm deliberately putting these videos in slow so you can see the movement of the capsule as it moves around. And we can actually again go and debulk it secondarily, even if you feel it's not good enough and there's a little bit of tension, and keep refilling the high molecular weight viscoelastic. So you have this kind of good stability. You would like to even make it go concave. You want to have the capsule really flat and if not bent downward. So, and you have to keep injecting and re-injecting and making sure that the rhexis, especially in these 4 quadrants, where you see that's where they will run out, the 2, 4, 7, and around 10. So those are the areas where you need to really turn them out, and you can get a decent rhexis even in that. What do you do when you have a runaway capsular rhexis? And again, this is something commonly we do see, especially in these 4 quadrants that I spoke about, the 2, 4, 7, and around 10. So here you see me going around, and at some point you see that it's kind of extending here. At this point, it's important to stop, inject OVDs, and use a sharp dissection. I like to use intraocular scissors to kind of go and just make a nick there, because pulling them and is only going to make things worse in pediatric capsules. So try to make a very sharp dissection and then bring it back in, and that kind of makes it easier to complete the rhexis. And just be aware of that tag that you have there for the rest of the surgery. Now, this was another child who had this was like a mature cataract. There was no view of the posterior capsule. And this is immediately after the lens removal. You can see this nice thick posterior plaque that we saw. So the first thing I'm trying to do is make a nick in the clear part of the posterior capsule and try to kind of go around it. But because it's quite big, you can end up doing a vitrector rhexis, and you have like a good cut rate and high vacuum. You just kind of go there and clean it up. Again, it's very tempting to kind of remove all of the white bits, but remember to be cautious and do only what is necessary in these children, up to the size that is necessary. In fact, a little bit of fibrosis helps to keep the posterior capsule really tight and nice, and not doesn't allow for extension. So once you have this, you have a IOL nicely in place. What do you do when you have traumatic cataracts? Dr. Jyoti spoke really beautifully about several scenarios, and what happens in rhexis in these cases, especially when you have these poor visualization. You can use an endolight. And here you see me, I'm doing a slightly eccentric rhexis because that's where the child is probably going to see. So you really don't need to kind of do a central rhexis in these children. Rather, you would like to center your rhexis onto the visual part or visual axis of the child. And once you do a slightly eccentric rhexis, you can just go ahead and put an IOL. There's a large iris defect inferiorly. And it's because it's large, we kind of hold on to it and not do much with the pupil as well. Surprisingly, this child did really well, 6/9, without much of echo, because the child was seeing through the lower part of the capsule. What about torn lens capsule? Sometimes in traumatic cataracts, what happens is the injury goes right through the capsule, and you can see this kind of tear that happens in the capsule. And here you see me navigating the capsule, but because the capsule is now adherent to the iris, it's not prudent to tear or tag it. Rather, it's good to do a sharp dissection like what I'm doing right here to kind of just nick it off the capsule so that you don't have further extension. So once you have a sharp dissection, then you have more space for the capsule to kind of give way as you do your rhexis. And I'm sorry about the going out of view, but you can see that the capsule, as I'm coming back, you can see this kind of lens matter adhered to the lens capsule. Here again, I'm showing you that this kind of pull that you see, the lens matter is now adhered to the capsule. At this point, again, use sharp dissection to kind of cut that part out and make sure you pull out the capsule. You do not need certainly a round rhexis in this. As long as you have a good rhexis which is intact, and you can put in the IOL, it's good. Now, what about these secondary IOLs when these traumatic cataracts where you want to put in a secondary IOL after a bout of aphakia? You can actually open up the lips of the anterior capsule with very gentle manipulation. So this is also possible. You can inject some OVD into the gap. Once you get a small gap between the two fused lips, you can actually open it a little and then inject viscoelastic to kind of flow through and create a cleavage plane as well. So here you see a gentle nudging, and then you can open up, especially in the early cases where fibrosis is not really set in, you can actually open it up and then place the IOL again. Now, after placing the IOL, I want to do a vitrector. So, but now I just want to show you a very gentle nudging of the IOL, and the haptic goes in beautifully. Post this, I wanted to do a posterior capsulotomy, but here I would prefer to do it through the pars plana route for this child. So we just put in a trocar and then go through the pars plana route, and I will show you how the through a vitrector, we can actually make a nice round posterior capsulotomy as well to kind of open up the visual axis for this child. This was a young child, and you can see that there was a fairly round opening that's seen there, and the child was doing well. So different approaches to the same cases. And then we have small pupils, and this is another challenging case for Rexis. Whenever we have small pupils in children, it's very important to expand them. So here I'm using iris hooks. You can see that we could use multiple hooks because I want to keep the incisions minimal. I'm using it through two side ports. This was a really young child, so I wanted to do a lensectomy and leave the child aphakic. So here we see I'm trying to put in few iris hooks through some incisions. Again, small eyes, small corneas are always trouble. So take care. And once you don't immediately tighten it in a serial manner so that you have this slow kind of dilatation that happens rather than pure mechanical pressure. Now here you can see the central calcified kind of a plaque. I'm trying to do a vitrectomy, but it's not happening. So here again, I use scissors to kind of nick that part out. And even after nicking that part out, I was not able to take it out using vitrectomy as a whole. So here I again chop it up into smaller bits, and then I'm able to emulsify it and take it in through the probe. So once that is done, then you kind of create a nice little opening through a vitrectomy, through vitrectomy itself, and you get this visual axis that can be opened up. And here again, I'm not looking to, because both the lips are anyway fused, both the anterior and the posterior capsule are anyway fused. We're just trying to look to make a good sulcus for the child with a good opening in the center so that the visual axis remains clear. And again, suture the ports for better stability. This is another new thing that did come up in the middle, and I did have a few cases which I tried, and I don't do it anymore, but this is just for the interest of showing you the technique. This is the Zepto Rexis that can be done. Here, this is made of a nitinol ring, and this nitinol ring has it's a collapsible ring. And then once you put it on and press the suction, you get this kind of perfect round Rexis that can be seen. And it's about 5 mm plus or minus 0.2 mm. That's the size that you look at. And this is not negotiable. You cannot reduce it or increase it. Once you do it, you see this little bit of an extension that happens. And once the Rexis is done, you just have to pull it out. You don't have to collapse it again. You just pull it out and you have this nice circular Rexis. Again, this can be done intraoperatively, and I think that's something pretty new that's come in. So thank you for your attention, and looking forward to the discussion.
Thank you so much, Shruti, for showing those very amazing videos. I need comments from Dr. Love and Dr. Jaspreet and Dr. Jyoti.
I mean, the very nice videos, some different case scenarios. It is just that probably the approach is different. Like the case you were showing where you opened up the capsule and then put an IOL and then put a Rexis. Probably I would have, because the anterior Rexis was quite large, I mean, it was not covering the IOL finally, I would have done a posterior optic capture in these cases.
Right.
So just to prevent that visual axis of pacification. And the other thing is, no doubt, staining is very important in these cases. I mean, and the problem with staining sometimes is when you have the subluxation and zonular dehiscence, the dye goes behind. And then once you remove all the lens matter, if it's white, you remove the lens matter, then it becomes a problem visualizing the capsule. So with the newer machines, probably like the intraop OCT, what we have, I have started using it more in these cases where I can't visualize the posterior capsule. So once I do that, probably it gives me an idea, yes, my posterior capsule is intact, and I just may need to make a nick in it and do some vitrectomy, take out that dye, and then do my rexes. Because these are traumatic cases, you'd never know what the posterior rexes is, basically how it's going to be.
I have one question with the experts and the panelists. If a child is presented at the age of 4 months old and if you're operating the cataract, if it's a bilateral or a unilateral case, what is your preference? Do we put the eye on that sitting or do we wait for some time and then put?
So the consensus is in literature is less than 6 months, leave them aphakic. That is the consensus. But yes, I mean, Dr. Jyoti has access to contact lenses. We don't have our profile of patients who come are different. So obviously we try to rehabilitate them with IOLs. But yes, I do a UBM now in every case, in every infant, to see the capsular bag size. Most of them are left aphakic because the bag is small. But there are a few where the bag size is adequate and I've been able to put an IOL. So in those cases where I don't put an IOL, I do both the eyes in the same sitting. So I'm leaving them aphakic.
So what is the bag size you look for, Jaspreet?
Yeah, so it's we just published that in JCRS. It's about 7.5 to 8 millimeters. That's what we are looking for, because there is some stretchability of the bag in children. It's an elastic capsule. So probably in that size you can do it. And when I mentioned bicapsular captures, these are some patients like PFVs or something where you have unilateral cataracts. You want to put an IOL because obviously leaving them with aphakic correction would lead to amblyopia. So in these, when I do the bag size, sometimes smaller. And these are the patients where I do a bicapsular capture. So you cannot take the optic into the bag. It's so small. So with the haptics, so it's just the optic which goes and the haptics are outside. So that 6 millimeters can go inside, but the 12 millimeters won't go inside the bag.
Only thing is resurgery rate increases if you are implanting IOL at a younger age.
Yes, if you're not doing a good adequate vitrectomy, probably yes. And the way we are doing it now, probably doing a posterior optic capture, the chances of VA are much lesser as compared to what it was earlier.
I have a little. Go ahead, Dr. Jyoti, please.
No, to be more specific, if the axial length is less than 19 and the corneal diameter is less than 10, you will not implant it. Also, when you do an IOL calculation, we do not get lenses more than 30. So basically, we know that if that power is less, and suppose it's 4 months and you are getting the IOL calculation to be about 40, and you're going to do so much undercorrection, you should again know that you are eventually going to give him refractive error because you're going to balance him for assuming that his refractive error is going to be best at 18. So you have to look at all these parameters and then decide that can I put in a lens or not. Because whatever said and done, with good hands, surgery comes very nice. But those who are new should not start doing in children less than 6 months, or even I would say less than 1 year, because the amount of reaction that shows up in a child with a small eye is much more. So when in doubt, keep the child aphakic. Even glasses do very well. You can actually have, and they do very well. And then if need be, you can put the IOL after about 5 years, and earlier if you feel the child is not rehabilitating well with glasses. So look at it as don't look at it like a standard guideline, but look at each case separately, and then you can plan what would be best for that particular child.
Yeah, I agree totally. And like Dr. Jaspreet said, in our part of the country, it's not just the availability, it's more about the compliance or the ability of the parents to be able to successfully and hygienically maintain contact lens. So I generally tend to err more on the side of IOL, particularly if it's a unilateral cataract. And like Dr. Jyoti said, if the size, corneal and the axial size is enough, I would go ahead and put an IOL, because even if you're left with a refractive error, managing that aphakia becomes very, very difficult. So yeah, if you can do in the bag, yes, then do it. Otherwise, then obviously don't do a sulcus IOL in anybody below 6 months or even 1 year of age. Just leave the child aphakic and look at other options, is what I would do.
But there are instances in older children where the bag size is where you have a good axial length, a good corneal diameter, but your bag size is not adequate, and you end up tearing the capsule when you're forcing a IOL. So measurements do help sometimes, and if you have access, why not? I mean,
yeah. If you have access to UBM, I think this is and what you said, measuring the bag size, a lot of us never really thought of it, and this is how we progress and get better and better. So if you have access to UBM, you must get it. I mean, yeah, it's a hassle to get it up in the OR under EUA, but it's worth all that trouble. Every little effort is worth for that child.
And sometimes if you don't have the UBM even on table, when you look at your bag, you will immediately make out if your edge of your bag is within your pupillary edge. Otherwise, you do not see the edge of the lens bag. That means you know it is adequate enough. So there are many syndromic children that we see, like Lowy syndrome, where you will see a bag, but the minute you go in, your rexus will realize, oh, your rexus is small enough. Bag is looking so small. So immediately you would know, yes, I would not go. So when you are doing a rexus, if you are not able to see the edge of the bag, that means you know it's adequate enough to put in an IOL.
But these are the children, sometimes the pupil don't dilate. And so
I said you have to clinically go. You have to pick up and see how, to what extent you're able to see. Yes, ideally where you have possibility of UBM, yes, please do. Wherever it is, it's best to be aware that you can or cannot do before you go in. But when you are not able to get this, at least you can clinically look at that way.
Yeah, before the UBM, I used to do that and leave them and not put an IOL. Because when I used to see the edge, I saw the bag is small.
And also, when in doubt, I feel like even if it is 1-year-old child, if your competence and your thing, and you are not, it's okay to leave them aphakic and then put in a secondary IOL much later on. I mean, I still feel that it's always good. You do what's best for the patient in your hands, and that's all that matters. So it's not about 6 months or 1 year. It's about how you feel and of all the things that come together from the patient side as well.
Any other question? Okay, so I think we had an amazing talk from all the speakers in today's session. Thank you so much, Dr. Vaishali, Dr. Jyoti, Dr. Shruti, for your lovely presentations. And thanks to our expert panel, Dr. Lav Kochagave, Dr. Jaspreet, and thanks to moderator, Dr. Divya. I think with this we come to end of this module on Phaco in pediatric cataract. So for all the attendees and those who are on Facebook and YouTube, we are throwing up the link. You can log in to that link, and this will take you to AI Scientific Committee modules, where you can just fill in 20 questions which have been prepared for you, and you need to get at least 40% correct to get the certificate for attending and passing this module. And thank you so much, Dr. Namrata ma'am, once again for giving this wonderful opportunity. And on this coming Saturday, we have module 5th on Phaco in subluxated cataracts. We'll be having some amazing case discussion by stalwarts in Indian ophthalmology. So thanks to all of you for joining for this webinar. Thank you so much.